Well, thank you very much. Thank you, Sanjoy and Thompson, for the invitation. This is an honor to speak here, and it's also very intimidating, I must say, mainly because there's been a lot of excellent works on the history of sleeping sickness, which I haven't done, and there's also a lot of specialists in the room, and I have to say that my knowledge of the topic is mainly from archives and old textbooks, and I clearly cannot compare with Jean and I suppose other members of the audience. So what I will do today is to present you, as the title of a seminar series suggested, to present you 5 lessons from history, 5 lessons from the history of the fight against sleeping sickness in Africa in the 20th century. And I will mostly deal about the West African sleeping sickness, the Gambiense sleeping sickness. The first 3 lessons are about classic and well-known aspects of that history. So if I'm too slow, you can manifest yourself and I will go faster. And the last 2 are about more about less known aspects of that history, but aspects that are maybe more problematic and which deserve as such discussion. So I'll start with the first lesson, and if you want, it's a lesson in the politics of international health. And the question is, what have we learned from what I have called with a voluntary anachronism, sleeping sickness exceptionalism? The idea, sleeping sickness exceptionalism, is the idea which shaped the response to sleeping sickness epidemics at the beginning of the 20th century. But sleeping sickness was a special disease which deserves special services, special staff, special methods, and of course special funds. So what was so important? Why was sleeping sickness so important for colonial governments, mostly during the interwar period? The first factor was a simple one. It's a demographic factor. Sleeping sickness contributed heavily to the demographic crisis which followed the colonial conquest of Central Africa. It is estimated that during 1890 and 1920, Central Africa lost half of its population. And sleeping sickness contributed to that. And particularly after World War I, the need for workers for the first great public works program in colonial Africa made quite obvious the need for medical action against sleeping sickness. This demographic crisis also turned somewhat obsessional for colonial governments, in the sense that it generated apocalyptic discourses about what was then called the extinction of the black race, and colonial officials could announce that their mission was above all a demographic mission. As a French governor put it in the 1920s, the French colonial mission was faire du noir, literally to cultivate the black people, to get arms to get to for work, basically. And the colonial doctors claimed they were going to save the black race, and that's a quote. Or another quote of the Jameau, French colonial doctors we will speak a lot about. The French colonial doctors' mission was also to wake up the black race, réveiller la race noire. Second factor is that the fight against sleeping sickness was not only legitimating European colonial presence, but it was also a matter of nationalism. Comparisons between imperial powers motivated support to colonial health service and publicity about their action. And the fight against sleeping sickness in particular was considered to be a test of the respective colonial capacity of the different European nations. And so this is not by chance that the two most significant programs of fight against sleeping sickness in Africa were in Cameroon, where Dr. Jannin experimented a system of mobile teams, and in Tanganyika, where the British colonial health services experimented an approach based on resettlement of population and destruction of the habitats of tsetse flies. These two countries, Cameroon and Tanganyika, you may know that they were former German colonies who had the status of League of Nations mandates. They were mandates of the League of Nations. They were not proper colonies. And that meant that the colonizing action of France and British in both countries was evaluated every year in Geneva at the League of Nations. And there were reports and there was debates and there was critiques about colonial policy. In the case of the French Empire, this factor is very obvious. The two former German colonies, Cameroon and Togo, which were French mandates after First World War, received considerably more money for their health expenditure compared to the rest of the French African colonies. And they received it essentially after 1925, when Germany re-enters the League of Nations and began to have a voice to criticize French and British colonial policy at the League of Nations. And the chronology is really interesting, and the creation of the first specially dedicated sleeping sickness service follows a series of articles in the German press accusing the French of not doing anything to fight sleeping sickness in Cameroon, in the former German colonies of Cameroon. And it is also not by chance that the French chose Ayos, a little town near Yaoundé in Cameroon. It is not by chance that they chose Ayos, which was actually the former German installation, the former sleeping sickness camp of the German colonial doctors. And they literally put the boots of the German colonial doctors, enfiler les bottes, I don't know if the expression translates in English. And so this is contemporary view of the Ayos sleeping sickness camp, which is partially ruined today, but this is recent views. And third factor, it has to be kept in mind that there is no automatic effect of demographic crisis and imperial rivalries to launch a sleeping sickness service. What was eventually decisive was the initiative of individuals who translated these issues to the metropolitan public and who managed to get political and financial support. That's what can be called some humanitarian entrepreneur, what we say in France, entrepreneur de cause. People who constructed the sleeping sickness emergency to the metropolitan public through films, conference, photographs, figures, stories, and who managed to get some financial support. And the most famous of them is clearly Eugène Jameau in France. He began to work in the 20s in French Equatorial Africa and then Cameroon. And you see the rounded face in the middle of the picture. And sleeping sickness with people such as Jameau was clearly the first media event epidemic of modern Africa, as the historian Louis White has said. And this is, in my view, how figures such as Jameau, which are very famous, this is how figures such as Jameau must be understood and studied, rather maybe than as saviors of Africa, as they are sometimes remembered. And this is one of the monuments commemorating Eugène Jameau. It's still in Yaoundé today, and this is a recent cult of Eugène Jameau in his native town in Saint-Sulpice-des-Champs in Creuse, in France. And you see that this cult is still very much alive and very much about Jammeh as the savior of Africa. I now come to lesson 2, which is now a lesson, a more technical lesson on public health techniques. The question in that lesson is what can be said of the image which is most immediately associated with sleeping sickness fight, which is the image of mobile teams, the system of mobile teams for the screening and treatment of populations. This system of mobile teams is important because it was gradually adopted by most African colonies of all empires, and also because it had a long-lasting influence on public health policy in Africa. So this is another image of a sleeping sickness team. So the first point to remember about these mobile teams is that they relied on a series of technical and managerial innovations, such as the tailorization of medical work. A very strict, what was called therapeutic chain was organized in those teams, with patients had to follow this chain. This tailorization involved a series of diagnosis tests, blood tests and lymph test, and also lumbar punctures. And this tailorization enabled very high cadency, with hundreds of patients treated by one team in one day, screened and treated by one team in one day. Mobile teams also relied on organizational innovations. Very strict logistics had to be organized in colonial capitals, and this is an image of the Leopoldville Center for Sleeping Sickness. And it also relied on a very strict and innovative at that time medical administration, with files and individual leaflets for patients. And lastly, it also relies on a very high specialization of the medical workers. Microscopist is even a wide specialization in a sleeping sickness team, and people were actually even more specialized than microscopists. There was the one who colored plates, the one who would look at the plates, the one who would check the plates. But the general principle was that most of the work was done by auxiliaries, and very specialized auxiliaries doing very codified tasks. This story demonstrates at least that tropical medicine is not only produced by the export of methods from Europe to the rest of the world, but is also a site of innovation. And this kind of tailorized and standard medicine had no equivalent in the metropolitan context at that time. So that was real modern medicine, and more modern in some ways than what was done in the metropolis in France or Britain at that time. So all that is rather well known. So I will come now to 2 or 3 questions about this system of mobile teams. The first question is, the classic view of these mobile teams is a very nationalist view, at least in France, and we often present it as a French system. Interestingly, we say a French system often in English, which shows that there's something interesting about that. The question of national styles is really a classic question in the historiography of tropical medicine, and for sleeping sickness, the cliche, if you want, are that the British targeted the vector, the tsetse fly. The Belgians focused on humans and on the control of the circulation of humans, what was called the cordon sanitaire technique. And the Germans, before the First World War, and then the French, focused more on the parasites and developed chemotherapy. And we can even say that the French synthesized the Belgian and German approach, controlling at the same time circulation of humans and treating with chemotherapy the populations. What I want just to point is that the things are much more complicated than those different cliches. And what is interesting is that this nationalistic imagery about the different styles had been produced by colonial doctors themselves, but at a moment where international exchanges were actually routine and very well practiced. So it's an interesting paradox that you need exchange and cooperation to imagine what distinguishes yourself. So that's a general point. But the international exchange were very important on the field with trans-frontier campaigns, for example, here in West Africa and here along the Congo River with Franco-Belgian teams working closely together on those campaigns. And the international relations were very strong also for drug experimentation, and it's a very quick map of how a new drug, which was the pentamidine, a drug experimented during World War II, how this drug circulated during the war through informal exchange on the ground in Africa at the time where relationships with Europe were cut. So that's at this moment that the drug was experimented, and that it was demonstrated that it was very useful for the treatment, but also for the prevention of sleeping sickness. And an interesting outcome of this moment of inter-imperial exchange is the creation of the first and also the last inter-imperial health organization. It was the Bureau Permanent International de la Tsetse de Trypanosomiasis. It was like a WHO specifically for sleeping sickness and specifically for imperial nations, France, Britain, Portugal, and Belgium. And the history of this bureau ended at the end of the 50s, but for a few years it was explicitly in competition with the WHO and really tried to defend sleeping sickness as a chasse gardée, as a private field for imperial nations compared to the United States and the WHO. Second point, that is a classic thing about these mobile teams is that the fight against sleeping sickness was an exceptionalism in another meaning, in that it functioned by a real sanitary state of exception. The fight against sleeping sickness relied on the interruption, often on the interruption of trade, on the interruption of the circulation of cattle and humans. It also, because the compliance of the population was crucial, it also required the suspension of the few rights that the population had under colonial rule, and the presence to the campaign was compulsory. Absents were exposed to prison penalty. There was incidents, riots, sometimes tragic accidents. So this made the state of exception very controversial at the time and among historians now. And it's something that we know quite well. The legacy and impact of this mobile team system has been very important. It's an obvious success in terms of epidemiology, and Jean will tell you more about that. But it also left a deep mark on the African public health systems post-independence. First, because the system of mobile teams in the 50s was extended to other targets, such as yos or leprosy or tuberculosis, and also because just after the independence, some post-colonial institutions were organized to continue the fight against sleeping sickness. And an interesting point is that in the former French colonies, the number of French colonial doctors working in Africa actually grew after the independence. So the classic story of the resurgence of sleeping sickness after independence because of the collapse of the public health system is a bit hasty. And clearly, if sleeping sickness re-emerged after independence in former French colonies, it was the French colonial doctors were actually the first witness of this reemergence. And also legacy, there's still very lively memories of this sleeping sickness fight, and this is a song which still circulates today near Yaoundé in Cameroon, a song which insists on the pain of injection, on the presence of the police, and on the side effects of the injection. I will pass on this lesson 3. I was just mentioning some current controversies about the history of sleeping sickness as regards the ecology and the epidemiology of sleeping sickness. First question, and I stole these slides to Jean, how to interpret this famous curve of decrease and then re-emergence of sleeping sickness. Was it only the Pax Britannica theory, the idea that the collapse of colonial health system gave way to the rebirth of a sleeping sickness, or was it something more complicated involving ecological balance, or also involving the end of the role of colonial exploitation, and in particular the role of forced labor and forced rubber collection by Africans, who appeared now to be one of the key factors in the big epidemic of the early 20th century. And the other dispute is about the mortality, the real assessment of the mortality of sleeping sickness, and the tropical textbook version, tropical medicine textbook version is that mortality was 100%, and there's alternatives interpretation, and even maybe a counter-history of sleeping sickness fight to be written, taking it not as a deadly menace, but also as a manageable disease. I will end with this lesson, which is now a lesson about pharmacology and public health policy. And it's the history of pentamidine. This history is interesting because in some ways the debate about sleeping sickness fight has often been a debate about human rights and horizontal approach versus medical rationality and vertical. It's been a classic debate going on. But I think this debate is insufficient as it leaves aside the very question of the uncertainties produced by the treatment that were used, and also the very question of the rationality of the campaigns themselves. The question that was not only were they oppressive, but were they always rational? And that's another question, and pentamidine is an interesting example for that. Pentamidine or Lomidine is the new drug of the post-war period in Africa. It was considered a wonder drug used in chemoprophylactic. Injections were given to the entire population of some region every 6 months and were thought to protect the entire population. That was called l'homidinisation totale in the French setting. So this is pictures of those intramuscular injections, which were considered very painful. Pentamidine is interesting because it worked wonderfully at first. Immediately after lomidinization, it was said that the infection index dropped vertically in the affected region. It was said that the study of trypanosomiasis was now something of the past, and the only remaining problem was to quantify more precisely the dynamic of the eradication. And the big question was how to model the coming of the curve to zero. And eradication, and this is a collector article, eradication was even unknown in some paper. Here a paper by Gaston Murat, who is a great specialist of French trypanosomiasis, who announced that sleeping sickness was eradicated in North Africa in 1954. But what is very interesting about pentamidine is the end of the story. In the 1970s, long after sleeping sickness was not a problem anymore, it the status of pentamidine totally changed. First thing, it appeared, laboratory experiments on animals showed that pentamidine was not actually protecting animals for more than a few days, and certainly not for months, as it was believed in the 1950s. And pentamidine in the 70s had behind it a long record of accidents which had cast serious doubt on the safety of the method. And the French military doctor René Labusquière, a great specialist, a former colonial doctor, a great specialist of sleeping sickness, said that pentamidine in 1974 was useless dangerous, and therefore uselessly dangerous. So this drug has the status of the drug has radically changed in 30 years. And that makes it a very interesting case for the historian of science to understand the reversal of the status of a drug. So what I was interested to do is not to demonstrate that colonial doctors were wrong, but to try to understand how they reacted to the contradictions that appeared during the campaigns with this drug that worked, but not for the good reasons, apparently. So first problem that they encountered, that the drug was apparently too efficient. During the first trial, for example, the doctors found that the controls were left uninjected in the village were actually protected also by pentamidine, by the chemoprophylaxis. It's easy to interpret now by the collective benefit of the treatment of a part of the population, but at that time what was proposed was that the tsetse flies actually benefited from the chemoprophylaxis themselves as they ingested some pentamidine by biting people injected with pentamidine. The other problem was that it was found that the drug was protecting populations not for 6 months, but sometimes for 1 or 2 years, without new case for 1 or 2 years. And it was very difficult to interpret this 2 years protection by one single shot of pentamidine, and the doctors had to make some complicated theories about the fixation of pentamidine in the body. Second difficulty, the failures of pentamidine. It was often found that individuals injected with this preventive drug were actually infected six months later. The colonial doctors investigated these cases, and they concluded that very often these failures occurred in what was called at the time évolué, which meant the colonial part, the population of the African population that was educated or rich. And their conclusion was that these failures were explained by the indiscipline of this évolué, which were not the usual African peasants that sleeping sickness doctors were used to treat. So individual indisciplines explain individual failures. Lomidine has also very strong side effects, and if you get a pentamidine injection today, you will have to be carefully monitored in the hospital. But at that time, the side effects were considered not that important, but important enough to lead the main producer of pentamidine, Specia, the French firm Specia, to launch a special survey of side effects and of post-injection accidents of pentamidine. And the conclusion of the commission was that the accidents always occurred in the same areas, near urban centers, where population, and I quote, have a stronger tendency to be emotional and cowardly, and to eat when told not to, which goes to show that their frame of mind is little inclined to discipline. So here again, indiscipline explains side effects. And what transpired behind this prose was a denunciation of Africans' uncontrolled evolution. which was the great fear among colonial experts, not only doctors, in the 1950s, at the time where anti-colonialism was on the rise in Africa. I am not identifying these points of contradictions only retrospectively, but at the time there was critiques against l'homidinisation totale, and especially there was critiques from the British colonial doctors who considered that the drug was too dangerous and the chemoprophylactic method was too costly to be generalized. And so they only use pentamidinization in small communities, but not in countries. And French and Belgian doctors consider the method was what they call the Latin technique. So the drug triggered national adhesion, and that was an important factor in the perpetuating of the method. So how to justify facing those contradictions? How did the colonial doctors justify the continuation of pentamidinization? Two elements were important. The idea that what mattered was the collective fate of Africans and not individual issues. And the second is, of course, the quest for total eradication. The risks were well known, but paradoxically, the problems encountered was one more reason to intensify pentamidinization. And this is a very strong quote by the Belgian head of colonial health service in Congo, who said that the problem of accident was not a reason to stop chemoprophylaxis, but it was one more reason to finish the work, and I quote, because we consciously sacrifice individuals in front of the collective problem which has to be solved. So this is a very strong conclusion. I will end with that just by saying that there was one exception to this reliance on the dream of eradication and the collective rationality, the case of Europeans. And in the case of Europeans, and as later explained that, pentamidine prophylaxis was not indicated because it was too dangerous, too painful, and not efficient enough. Okay, I finished with that, and my conclusion was about the study of some accidents, big accidents, not due to the effect of Lomidine, but due to unsterile use of Lomidine solution, which led to a series of terrible accidents in Cameroon and other countries. And I proposed the study of how the colonial doctors reacted to these accidents, and how they also found here one more reason to extend again Lomidinization to go to eradication. And the last point was just an indication of emerging researches considering the role of injection campaigns for sleeping sickness, but also for other diseases such as yaws, leprosy, in the spread of blood-borne pathogens such as hepatitis C. And there's been recently a few very interesting research on that, and that's one more reason to study this history of Congo.
Central Africa, spent at least 12 years, I think, there. I was reading the literature, specializing in these. We go on a bit more, John, I think this is better.
Thank you very much. I will try to be quite short, so I would like to congratulate Guillaume because it was an extensive presentation on these three, and spoke about the colonial doctors and French attitude. And I don't know if you know that, but in 1940, UK people were speaking about the French like a battalion of eccentrics. So I hope we wouldn't be perceived like that today. So I will start. I'm really happy also to have around this table many colleagues from NPD, but also a large panel of high-level scientists for TDR, and it's a real honor for me to speak today. So, just to restart a long time ago to summarize more than 100 years of history, we could, of course, sleeping sickness was existing before. It's quite well known, but finally the first date, which is very important, is 1885, when we colonial countries signed the Berlin Treaty, and they started to rush inside Africa for defining the borders. And finally, a few years after, they started to discover a new disease, and nobody knew what was this disease, and finally it was sleeping sickness. And remember that during more than 20 years at that time, the best scientists finally in the world did a fantastic job because they identified malaria, they identified the schistosomes, etc., all tropical diseases, and suddenly, at the beginning of the cycle, a new disease was emerging from Africa. It was sleeping sickness, a killing disease, and I just put three names here who participated to this fight. You have, of course, Louis Pasteur, who was the father of the infectious diseases. Paul Ehrlich was the father of the magic bullet, which means the father of the modern chemotherapy, and the first drug developed in this world was for sleeping sickness. It was the trypanosomiasis. And I would like also to mention that people like Robert Koch, because there was a big rivalry between Germany and France, was really very involved, and many people don't know that Robert Koch spent 4 years in Buvuma Island, and you can see a photo he made himself here for establishing a big camp for treating sleeping sickness in that area. So it's not only the TB father, but also he made a big contribution to sleeping sickness. In 2 words, we started probably by the first epidemics around 1885 in the north of Congo, but the real big epidemic, the biggest one, I would say, started around 1910 or something like that. And you can see this curve which has been showed by Guillaume, and you can see what happened until 1994. And finally, people made, thanks to Jameau, finally, it has been said by Guillaume, but Jameau was one of the main conceptors of the early diagnostic need, and also he was saying if patients are not able to go to the hospital, we have ourselves to go to the patients, and it was the beginning of the story of mobile phones. After this concept has been, of course, destroyed to be fashioned. So I will speak about it after some lessons from history. At that time, Labuschagne, the same one, it was not eradication, if I can, but elimination, because he was saying it had become commonplace to say that trypanosomiasis is almost eradicated. Yeah, also foci are relatively rare, they are nonetheless eradicated. And restarting, based on these few cases around Central Africa, imagine that in 1964, all the teams examined 11 million people and found 11 cases. So it could be a very good lesson today for all of us, but nobody wants to do that today. I will come back. Now, what has been done? We restarted to use the same strategy, I would say, and I participated. My colleague Simao and Joseph here and some people around this table participated to fight against the big authorities to refuse the concept of primary health care applicable to trips, but we continued with the mobile teams. And you can see that now, in 2009, we are approximately in the same situation that in 1960. So 50 years after, I'm thinking that it would be nice to try to think about possibilities for eventually keeping this situation like that and not restarting 40 years of epidemics after reaching quite the elimination. So we have to learn some lessons from the past. Was it the golden age? I don't know, because around the 60s, finally, I don't know if it's colonial or not, because I'm thinking it's not the matter. There were dedicated people, for me it's enough. But HAT, human African trips, has been eliminated in 1960. YOS has been eliminated. If you are opening the small book of WHO, you can see that in 64 YOS were eliminated. Just for information, we have reopened the program of control of YOS last year because, of course, it's restarting. Kala-Azar in some areas has been eliminated. Malaria, and you can take the example of Venezuela or something like that, has been eliminated. And now, none of this disease, finally, is eliminated. We have just to restart everything. So, I would like just to be you asked me to be provocative, so no, I will try to do it, and to ask some bad questions. Why such a huge collection of failure? Because finally, we have no real success apart the smallpox. And all the other diseases are restarting or moving like that, like a wave. So the first thing we could say, and I don't know if we can learn from the past, that elimination was considered always as a new definitive status and not as a permanent process to be maintained and to be adapted over time. Because we are always speaking about criteria for elimination, but 2 hours after the meeting would be finished, the situation is different. So it's a problem. So the problem is the problem is that activities have been abandoned before, or the problem is, or could be, that the same activities continue to be performed? And it's quite a good question, and I will try to provide some response. Another question, do we have the capacity to adapt public health policies to reality? And we could take, again, the lessons from what happened 50 years ago, because we know that it has not been done. And can we assume that the problem was a continuation of doing the same when the conditions were different and the support of the society, mainly politicians, was lost? So there's here a few questions to be raised. I would like to come back very quickly to the concept of sustainability, because sustainability is the master word all around the world. So, as everybody knows, it has been initiated by our previous Director General, Guillaume Lachenal, in 1987. What is interesting is this assumption that this concept doesn't arise from a phase of scarcity, but always from a period of abundance, which means that we want to continue and sustain something for which we are happy. If it's not a success, I don't see why to work for sustainability of unsuccessful, I would say, things. And it's very, very important, which means that finally it's very important to think about sustainability, but it's also very important to consider to do the proper job for achieving the control of this disease, for finally reaching an elimination to be sustained. So I will go. So there are some obstacles, for sustainability, apart the fact that, in general, we are speaking more about sustainability than about the capacities we are putting for controlling the disease. That is another story. The first is the punishment of success. And I would say it's largely what happened for sleeping sickness 50 years ago, and it's a problem me and many my colleagues are facing today is this punishment of success. What happens? As soon as the number of cases is going down, governments are reassessing priorities in light of the new burden of the diseases, and finally, they are withdrawing resources. The national programs or capacities are weakened or completely dismantled, and we saw that not only for sleeping sickness, for many other diseases. The knowledge as expertise, okay, is becoming very low because there's no interest for that. The attraction for scientists or young medical doctors is going for other diseases. It could be malaria, it could be HIV, maybe tomorrow it could be the flu, I don't know, but finally people have no interest to come for studying a disease which is quite eliminated. And of course, today, as there's no other collaboration, NGOs are leaving as soon as the number of cases is decreasing, which means that it's a real punishment of success because you are investing, you are working a lot, and I'm thinking to people who fight it for sleeping sickness 50 years ago, and when you have quite finished the job, everybody is coming in this kind of room explaining to you that it's largely enough and it's time to think about several other things. Another obstacle is probably the fear of change. We are, some of us, sharing largely, and it's coming probably through the risk of believing that success is permanent and that it's unnecessary to adapt. And this kind of attitude is a strong determinant for failure. So one question, is it satisfactory to continue with the same programs under conditions of flu infestation today? It's not only true for sleeping sickness, but it's a good question, I'm thinking. And finally, it's generating a lack of holistic vision. It's a wrong process of decision making. It's not a timely process. There's no innovation. And if we are continuing this kind of reasoning, we can say that probably our children could take our place for me or Perry or those of you to restart to struggle sleeping sickness in 40 years. And probably at the end we would have the same seminar here. We would be happier. Another obstacle, which is for me quite interesting, is the tyranny of small decisions. It's an interesting concept which has been developed by Alfred Kahn 20 years ago, no, not 40 years ago, sorry, and it shows how small decisions, okay, which are good decisions, finally, are accepted by everybody. But if you are accumulating very good small decisions, it could lead to a completely wrong macro behavior. And it's very, very important because when you are speaking with people or doing thematic discussions or something like that, all small decisions seem to be very, very good. But the problem is nobody is here for saying, okay, now I'm taking the 20 decisions and I will do the analysis for being sure that it's leading to a normal and correct concept. Okay. Another one, and it's if you are looking for sleeping sickness, about the report and the Sleeping Sickness Commission and the League of Nations, etc. debate, you can see there's this problem of notoriety bias. The problem is that some problems or facts are overrepresented, and it's leading to an effect very similar to fashion. The second thing is also, and I hear a citation from History, it's quite interesting. We need to look at our priorities in a more objective, analytic way, free from the understandable inertia of yesterday's activities and fashion. We have a real tendency, and it's probably natural, to always coming back to the big things as the classical thing. The problem with the notoriety bias, and if we are studying this history, and probably you did it, Guillaume, it's interesting because all the committees which has been set up for defining the strategies for all these diseases were quite only made with the highest science. The problem is that, sorry my friend of Diderot, it's absolutely brilliant people, but they are not here for taking decisions or for doing politics. And the problem at the end is that this mixture, is really deadly for getting some good decisions. So it's a real problem for sustaining elimination of it. The last one, I'm always presenting this one, it's my fight, you know. As everybody knows, half of the WHO is mobilized for calculating the burden of diseases, and we have a new god, which is DALIs, okay? It's a very, very interesting concept because it's a fantastic way for trying to evaluate the weight of the diseases, and we are working very, very hard with the data we have, of course, for defining this burden. But the problem is with the calculation of this burden is what means is BODN calculation for focal disease. I'm speaking about sleeping sickness, okay? If you are taking DRC, for example, Democratic Republic of Congo, you have 70 million people, and you have some foci where the disease was very, very active before, I would say, because they work a lot now. So the other was to say, we will put the number of patients of this foci, and as a denominator, we will put 70 million people, which is completely stupid. Because it means that the ranking of the disease in terms of priority was very, very low. And if you read, there was a paper in the Lancet, it was 15 years ago, made by Congolese people. In some foci, the first cause of mortality was sleeping sickness and not HIV. So it's just to say that it's not so easy to speak about. And finally, generally, through this way of ranking things, efforts for controlling or eliminating disease are rewarded by a growing interest from authorities and from all the groups around. So it's a real problem, and we are advocating, or I'm advocating at least, for developing a new indicator based on ethics. Because the ethics is quite important finally, and it's my personal thinking. So I would advocate also to say that as there's the matter, you know, there would be the antimatter, as there's DALI, we would have to think about an anti-DALI or I don't know what, which could complete the panoply we have for estimating the burden of disease and the possible success we can get. 2 words about this interaction of science, politics, and decision making. It's very important. We can't do public health with only science. We can't do public health with only politics, and we can't do it without any decision-making process. So I will go here, and I would like to come on that just for starting the discussion after. If you remember Max Weber, it was one of the founders of the modern sociology, and he was speaking about science and politics. And he was saying that science is based on the ethics of convictions, which means, if we are translating it for science, it's quite a caricature, but you know, it's just for provoking you, but saying that the scientist is saying, I do what I believe in without giving any importance to the consequences, which means that science is driven by the ethics of truth. At the opposite, for the politics is supposed to have, sometimes we have some doubts, politics have an ethic of responsibility, which means the role of the politician is to say I'm responsible for what happens with my acts, which means that politics is driven by an ethic of responsibility. And clearly, we see that there's a real need for joining these 2 concepts, because we need to have this ethics of truth, we need to have this ethics of responsibility, but probably by encountering these 2 ethical positions, we could start to make a very good public health. About the decision making, it's also something very interesting, because everybody is always saying, but who took this decision? And finally, nobody knows. Just to remind that decision is different from the choice. And Hirschman was saying it's here, men and decision makers never know very well what they want. They are discovering their goals, often new goals, through their experience, which means their decision. Just to say that finally this way of thinking is really something professional. And when I was speaking before about this bias of notoriety, it's just to say that the best possible specialist in molecular biology is not always familiar with the way of taking decisions. You see what I mean? Now, very quickly, how to improve the situation, in my opinion, it would be useful, and it's for the discussion, and we can relate all these things probably to sleeping sickness because it's full of examples like that. And the question has not been asked in 1960 when they eliminated sleeping sickness, is what we have achieved permanent? And the answer is clearly no, of course. And it's raising to the second question, how can we make what we have achieved permanent? Okay, so it's a very, very important question. And after the second round of questions could be, do the same activities carried out to achieve success serve to maintain it? And it's a real, very, very important question. It has not been done in 64 with sleeping sickness, and some people in the room were present sometimes after, and we know that no change has been made, and people continue to do exactly the same, and we know that it has led to a big catastrophe. So, is it necessary to do something different? The response for me is yes. But now the question arising is how to do something different. So, I would say doing something different implies thinking differently. And I would like to refer to Immanuel Kant. Everybody knows that he said the very well-known sapere aude, which means dare to think. And it was the motto of the Enlightenment. It's just to say, we need, all of us, when we are speaking about all these diseases, when we are looking back on these three, when we are looking back on this huge collection of failures, where people worked so hard, were so committed, we have not the right today to destroy the work which has been made by all these technicians, medical doctors, scientists, etc. So my praise to everybody is just dare to think, and we will see. Just 2 or 3 things. Here it's just something I like. Finally, Hirschman was saying trespassing is often used in a negative sense in the United States. For example, in notice boards that say no trespassing, viewing it as a violation of private property, but in my view it can have a positive value. It can mean stepping over the borders between one discipline to another without seeing them as rigid division. It's very well known, but finally it's so rare to see that. So, one question, is sustainable elimination of diseases a dream? The elimination of neglected tropical diseases and the sustainability of the achievement require our imagination. But take care of not dreaming too much, because as Crozier said, big organizations are characterized by strong inertia, which leads to the fact that except if a rupture occurs, changes will unavoidably take a long time to happen. I suppose it's quite familiar for some of you, which implies that this change should have been prepared a while ago, which means don't wait the elimination of your disease for starting to think about the sustainability of elimination, because you would complete the collection of failure. Thank you very much.
Thank you for these really thought-provoking thoughts. I'm sure some very interesting discussion here. We also have about 20 people online from all over the world who have sent us some questions. For their sake, it would be good to repeat the questions they get in the mics. the economic aspect of the drug. Basically, I'm very curious. Today, that's basically the how debate. But I would be very curious to find out that the peak of the campaign principles of the family, what were the scientific evidence that the manufacturers were achieving? What lay behind an economic interest to perpetrate the use of pentamidine? There's some evidence, some indications for that just to aggravate, put more forward this idea that is a lesson we have to learn. Because obviously everything is happening before the health drug regulatory authorities are kicked in, before the ethical committees are kicked in, etc. So I would like eventually to see a little bit more research as best for that part of the
Thank you. So I repeat the question. The question was about the economic aspects of pentamidine. This is a very important question. First thing is the archives are difficult to get because, as you know, drug companies merge and we've got a very special relation to memory. So the names change. So Specia was Ronpulang, which was then Aventis, which is now Sanofi Aventis. And the archives are in a ruined factory in Besançon. And the last building standing is the archives of Specia. And there's very few things on pentamidine, but so I cannot give you the figures. But what I know is that Ronpulang and Specia, this firm, has a very close link with the French state. It's what historians call the French state capitalism. It was relying heavily on public markets for its, and relying heavily also on the African market, even after independence. And that's a classic feature of the French economic history, that our exports were relying a lot on the kind of a private market in Africa. And Ronpulang did half of its exports in Africa, mainly with Nivaquine, but also with other less known drugs. So I cannot give the figure for pentamidine, but what is clear as regards the decisions made was that lots of former colonial doctors, a few of them, but some very important colonial doctors, were working after their retirement in Specia. So that's and the colonial doctors was a very structured professional body with a real family spirit. So Specia was part of the family, and it was in these networks, in these very friendly networks, that decisions were made about pentamidine and these drugs. So that's a classic story of French economics. If you do the story of health and oil in Africa, it's basically the same family stories, and that's really
comments.
So the question is, as the pictures change today, yeah, I think the context has changed a lot. We're not in the same era of state and industry. Ronpulang and Specia were national industries, strongly tied with the French interest. I think we're now in a more multinational world, which doesn't mean that there's no problematic relationship between decision makers and the industry, but the map has clearly changed. your question is about the role of the Germans today? Yeah. Hmm. Hmm. I can answer the first one and the role of the dynamics of imperial rivalries in the support of the public health system. I think you can see that also today with that different map, but the competition between African states as regards who will be the good students of the backers of international organization is an important element of the dynamic of who will get the most people. So you got another types of international competition and kind of the market of aid, the market of support is with a very different map, very different context, is still an important element of the dynamic.
To complete about these rivalities, remember that, for example, Jameau, who was speaking about this famous guy, was working in Togo in 1911, wrong, and finally he learned a lot from the German way of organizing the system. But remember also that when all these people start to implement these strategies, we were exactly during the First World War. And it was not only a scientific rivalry or something like that, but it was more acute. And remember also that Jameau probably developed something similar to the German way of establishing these campaigns. Jameau has been heavily criticized in France by having adopted the German way of thinking. So you know it's not so simple, and before you was really very Now, I would like to, it's very interesting because this sentence, Guillaume put and I put before, is coming from a debate at the National Assembly in France, and it has been said by the Ministry of Colonies and the Ministry of Finance. And what is interesting, if you are looking back in history, at the beginning of the HIV epidemics, I remember some articles were saying there's a big risk of living in empty containers. So it's something incredible and it would have been to be explored. But at that time, we have to remember, that's horrible, I agree, but this colonization was made for getting the maximum of resources. And finally, people were saying in Europe, when they were meeting together, we have invested so much in terms of money, in terms of human resources, etc., that we have to fight this disease because we would have a problem. It would be impossible to extract natural resources from Africa. It was really something very important, which means that, again, the decisions are not very often based on scientific evidence.
Whether it would be very interesting to examine the correlation between Pax Britannica theory and Stephenson's highs and lows. This is from Vera Compton. The speakers heard me.
So can you say it again?
Would it be interesting to examine the correlation between the Pax Britannica theory, highs and the lows of Stephenson?
Yes.
What are the connections?
Yeah, so the Pax Britannica theory is an expression of John Ford, who wrote a big book on the ecology of the African cities. And his book was actually an attempt to demolish this Pax Britannica theory, which is the theory that sleep sickness re-emerged because European nations have given independence too quickly to Africa, and that we haven't had the time to finish the work, and that Africans are not responsible enough to finish it. And the aim of his book was to show that the picture was much more complicated. First, because in large parts of Africa, colonial doctors actually stayed and were even more numerous after independence than before. And second, that there was other factor of the dynamics. Ecological factors, consequences of the campaigns, and some authors argue that pentamidine campaigns actually masked the epidemics by sterilizing the blood compartment, but by letting cryptic infections that cannot be diagnosed. So that led to an easy re-emergence of sleep sickness, which was actually circulated. That's just an hypothesis, but there's alternative explanation, but just the collapse of the system. But John Ford, I think, used the expression generically. Pax Britannica also applies to the French empires and to the Gambian state. In his book, I mean, he really defends that. And he even goes further, and other authors even goes further, saying it's not the sleep sickness epidemic is not it's not a question of Pax Britannica, but of Velum Britannica. It's possible to revisit the history of sleep sickness as a consequence of colonial exploitation, especially at the beginning.
Terminology is important. Apart from daring to think, we also have to be not inventive perhaps, but be ambitious with our terminology while also being careful. So do you see a difference between just saying elimination of a disease, or is it more important to always say sustainable elimination of disease? Because for you that sustainability factor seems very important.
Yeah, it's clear because for me, but I'm not alone, elimination is just something controlled. And that shows that the only definitive elimination is the eradication. So the idea in general is to, when you are reaching the status of elimination, and we are not speaking about different criteria, something like that, the idea is to maintain this status. And we see very easily what I said, but it's classical for everybody. As soon as progress have been made, the activity that the idea is that disease and not only sickness have stopped. So the main goal today, and for everybody, the major concern is how to sustain this very, very low level of transmission, I would say, in general. So the demonstration on how to translate an evidence into a disease.
So just be nothing. So a sudden outbreak of disease and yes, and I wasn't saying that. You said that. It's sustainable. It becomes sustainable. Sustained support for a while. Yeah. Useful question. Even though you're coordinator?
I will discuss after.
I think you've won some brownie points. But thank you. Very important comment about donor fatigue. Because I think having studied the smallpox eradication campaign at the very end, 5 cases could actually make sure the donors got interested again, Swedish and International Development Agency. So it was seen as useful for some people, some managers. Please.
How do we bring this to an end? It cannot be done by researchers looking at the disease or by control people looking at the science. I think it has to be done by somehow facilitating this. And I hope the new paradigm that we create and the new associates that we create cannot be bad. Because one of the problems that I see is these new initiatives to promote research, new initiatives to promote specific control acts, maybe bringing these two elements together are actually separated.
Just 2 words for in general, I fully agree. The main thing I would say for us, and because it's not, the idea is the control is a continuous process. I would say there's a phase for control where you have to develop activities, etc., classical. But at what time, and it's what all of our colleagues are facing now, is there's a moment where the classical tools or methods or everything can't be applied in a proper way. And it's here we have to think a long time ago about it. And it's here, in my opinion, it's what I'm trying to do finally, is to convince the research part, I would say, to concentrate on tools or new methods, or I don't know, we could identify for ensuring, if I can say, the sustainability of this country. Because behind that, we have been, and Felix is there, you remember, accused of being vertical, and some others were vertical, and the other one were oblique. So we like that a lot, and we are spending days and days for speaking about it. The other is that if there's an epidemic, we need to be vertical, and the story of the flu is a fantastic example today, to show that it's not only a problem of dogma, it's a problem of reality. As the control is becoming better and better, of course we are coming more and more horizontal. The key for the sustainability probably is going through the integration process in, I would say, peripheral healthcare in general. The problem is for ensuring this integration, you need to have at least some adaptive tools. And in my opinion, it's here the collaboration, I would say, must be very, very strong. Because there's some part of control which are remaining, there's a part of research, fundamental knowledge and everything. It's always needed, of course, but in the middle there's something which has been just to be cooked very, very carefully, not only between control specialists or diagnostic specialists or drug developers or something, but also with some other public health people, just to think how could we try to ensure the sustainability for control or for elimination. And I fully agree.
Excellent. Merci.
Enfin,
Allez, ciao.
salut, chef.
Fantastique.